What? Setting up your meeting for Facebook Live. And there we go. You guys see it? And okay, so welcome, viewers. Hopefully people will come in a little bit, and if not, we're gonna record. We're gonna put, if it's okay with you, Dr. Propst, post it for people who can't be here right now. Dr. Propst, thank you for joining us. Dr. Propst is a pediatrician, board certified pediatrician. Am I correct?
Correct.
In Houston. And you are very active in issues that keep everybody really, but especially children safe. And I know you have been very active and persistent in trying to get the right information out there about COVID-19 and the dangers thereof and what the correct policies should be. Let me also introduce one of my co-host moderators, Nelsine Alford, from Arizona, biology teacher in Arizona. I specifically sought out a biology teacher for this particular topic, the educator of future doctors. Michael Hull, the founder of the group, is also here. Hello, Michael.
How you doing?
And I want to go ahead and jump into this. If anybody is here already watching, please submit your questions in the comments bar of the Facebook Live video. And Nelsine will be tracking those and submitting those to Dr. Propst at the end of our conversation. Dr. Propst, can we start with, there's just so much crazy back and forth about, is it safe, is it not safe? I'll tell you right now, as a teacher, it's honestly exhausting, because a lot of people have a lot of opinions, and many of them are uninformed. Many of them are opinions that are derived from, just like with a lot of topics like climate change, teaching itself. You have a lot of experts who say one thing, and then you have people on the other side of that issue that say, well, I've found an expert who says the opposite thing, therefore this is clearly a debatable issue, when oftentimes it's not really. Dr. Propst, I've talked enough. What do you think is the correct benchmark for reopening schools, and how did you get there as a physician?
Yeah, so that's really about the million-dollar question right now. And there's not a simple answer. I wish there was. There are so many factors that go into it. Number one, I would say, is that obviously, if we're talking about opinions, everyone, or the vast majority of teachers, parents, pediatricians, of course, would love for school to resume the way it did last year and 2 years ago and 10 years ago. We're in a different time, and it is really important for us to assess where we are right now. And that means doing it on the local level. That doesn't mean doing it necessarily as a nation, because there is so much variability across the country right now in terms of incidence and prevalence of COVID-19. I'm in Houston, and I can speak to what's been going on here. We currently have a positivity rate in the Houston area of about 23 to 25%, meaning about 1/4 of the population, or 1 out of 4 people you might encounter on any given day, is likely to be positive. Now, Texas statewide is at about 13%. So still not great. That's far higher than any public health official or epidemiologist would like to be seeing right now. If you're looking for a number and just want to hang your hat on a number, 5% prevalence or percent positivity is what the WHO, the World Health Organization, and the American Federation of Teachers, for example, have used as a benchmark. Now, that needs to be taken in context as well. So is there one school, for example, that might have a ton of space, a ton of outdoor space, and be in an environment where class can be done outdoors, where certain age groups can be in person and certain age groups possibly not in person? If there is that sort of mythical ideal school campus, things might be possible. Spacing might be possible, hand hygiene, bathroom hygiene and etiquette, masking, obviously. There's so many layers and factors to what would make in-person or face-to-face schooling safe. Do I know personally of a school that fits all of those criteria in my area right now? No, I don't. And so just based on the numbers, based on the physical space, based on the resources, obviously, a huge portion of this is financial as well. There really isn't just that one magical number that it all distills down to.
Sorry, Michael, your video is popping up, so I muted you. There's some sort of feedback on your side, but what's your question, Michael?
I just wanted to ask, so say you get to that magical number, how quickly, if you got like 1 or 2 kids that were positive for COVID-19 in a place that was relatively low infectivity, how quickly could that spread within a school? Would that be contingent on how they operated, and how can we really be sure that the schools will be funded properly to have the types of prerequisites for a safe reopening, like a testing infrastructure, for example? I'll let you answer that, and then I have some more questions, but we'll start with that. How quickly could it spread in a region with low infectivity? So if you're good now, will you always be good? And how fast could a school reopening be a catalyst for an outbreak?
Right. So that's an excellent question. And again, there are a lot of facets to that answer. The answer to your one specific question, if you're safe now, or if you have a low percent positivity now, are you done? Is it over? Absolutely not. I mean, all it takes is a couple folks traveling to a high incidence area and coming back, not realizing that they are infectious, maybe being asymptomatic spreaders, et cetera. And there you go. In terms of the number of cases, let's say, in a school environment, and the possibility for wider spread in that environment, that is a trickier question, and that the studies are showing more and more will depend on the age group of the age of the person infected. And so, for example, right now, the highest rate of infectivity or transmission appears to be adult to adult. So if you were, let's say, to have a teacher or a cafeteria worker or a staff member who is highly present and visible and throughout, let's say, a school campus, particularly indoors and in smaller settings or in a break room or bathroom, for example, you have a higher risk for that to spread more quickly. The next highest incidence is from adult to children, and that is specifically age dependent also among the children. So there was a huge study out of Korea, really well-run study that was in the Emerging Infectious Disease Journal not too long ago, that described and stratified school-age children and showed that 9 years old and under were less likely to spread COVID-19 to adult household contacts. However, older kids were more likely to do so. So the percent of infectivity, I think it was about 18% of positive household contacts from an index patient who was between 10 and 19. So 9 years old is sort of the cutoff, at least from that study. And that was a really huge study with about, I think, about 60,000 individuals participating. So it's a complex answer, but the bottom line is all it takes is one. All it takes is one. And if that is one particularly who is coughing or not masking properly, or I hate to even invoke this issue, but we have issues with stool spreading, especially among kids. So, not closing the lid before they flush. There's so many little missteps that can happen and have huge reverberations.
Can I ask, so when you say adults, like what is the definition of adult? Because I teach high school students, so 18-year-olds are physiologically adults, So really, older teens definitely are in the higher risk group. 20s, certainly higher risk group. And here in Texas, for example, we've seen a real spike, and I believe in Florida too, of positive cases and hospitalizations among people between age 20 and 40. So I think we all agree those would be considered, younger adults. So one of the benchmarks that a lot of people are going towards, and you said hang your hat. I mean, I feel like it's smart to hang our hat on something rather than just see how it goes, is 14 days of declining positivity, like 5% new infection rate, 1% overall. I think I have those numbers right. Like, do you think those are good numbers, or that we should shoot for before we reopen schools?
I think that's certainly something to shoot for. Is that the sole factor that would make the decision to open or not open for face-to-face learning? No. But I think as a community, absolutely, those are good benchmarks to try to be shooting for.
Okay. You can again only speak for Houston, but maybe you can speak beyond Houston. But how are doctors and caregivers feeling right now? Because I know how teachers are feeling. Many teachers terrified of going back. And how does the medical community just generally feel about schools reopening and what that might mean for ICUs and so forth?
So there's a huge variety of opinion. The facts are the facts, and then there are the opinions, and there's somewhat of the economic issue and the politicization. And I certainly know families that have 2 physician parents and have younger kids and are trying to figure out how to navigate the educational system with a parent working in an ICU, a parent working in an ER, and now their 2nd and 5th graders at home doing virtual learning, which obviously on their own or left to their own devices would probably result in more video gaming than actual online education. So there are a lot of factors there, even for any of us. That said, I can certainly speak for a portion of the pediatric community, and we have our eyes wide open going into this fall and this winter because every year we have that seasonal variability of viral transmission. So we get flu, we get RSV, there are certainly other viruses that are seasonal and that spike. This year in particular, how we address the child who is coughing and febrile will be in play. I don't have a clear answer. I don't think anyone does quite yet. How we will, the resources that will be needed to distinguish a child who might have COVID-19, for which among children, the predominant symptoms still are fever and upper respiratory issues, so cough, congestion, etc. Very similar to RSV, very similar to flu. That is a huge question mark and really creating a lot of anxiety, I think, among my peers and colleagues I will say also for myself, just personally, I was following this as it was evolving in China before it hit the US. And I recall having discussions with people and basically saying, it's only one plane ride away. It's coming, it's only a matter of time. I had the same discussion with colleagues when Ebola was hitting Nigeria particularly hard. And some of you might know that Houston and Texas, but Houston in particular has a huge Nigerian community. Dallas apparently does too. And lo and behold, there it was. So, this isn't unprecedented, I would say, and I don't think anyone should have been caught off guard or surprised that it hit here. So going back to March, starting about the second week in March, every single patient, every single day, whether they are a well child check, a newborn, a rash, constipation, whatever mundane issue might be coming through the door, I've been wearing an N95, goggles, and gloves. Every single patient, no exceptions. I have actually found, and it even happened this week, that I was in a room with a patient who now, of course, our parents are required to wear masks when they're in the office. I'm in a smallish exam room for about 10 to 15 minutes with a mother and her child. Her child is fine. It was a well child check. And of course, I was wearing my precautions that I've now, the PPE I've gotten used to putting on. And lo and behold, 2 days later, she called our office and said, oh, I had symptoms yesterday and today I'm positive. So it's happening. We're seeing that all the time here in Houston.
So I heard Dr. Fauci say that if you had a face shield and a mask, it offers perfect protection. Now, would that be the case? Assuming you could gain compliance by the kids to keep it on the whole time, would that be perfect protection? And then the other question I had was lunch. Can lunch possibly be safe? We shut the bars and restaurants down for a discrete reason because you're packed into a certain room. You have to take your mask off to eat, and according to certain district plans, they've got us monitoring the lunch. Is that even possible? So, is there such a thing as perfect protection? And would eating lunch or breakfast in a school even be possibly safe? Is there any way it could be done?
Yeah, so I certainly admire and idolize Dr. Fauci in many ways. I certainly am loath to contradict anything that he might have said. I haven't heard him say that specifically. That said, I don't think there is perfect protection unless we are talking about the, full biohazard containment suits that you're seeing in certain ICUs. At certain collection sites, for example, and I don't see students or teachers wearing those outfits. So, we are doing what we can. Of course, we would love to have perfect protection because we're around it all the time. And in terms of the face shield and mask, certainly that combination is preferable to either alone. Masking, though, if consistently done and properly done, has been shown to cut down on the spread of COVID-19. I certainly would not recommend face shields alone. There would have to be proper masking underneath it. Lunch brings up, of course, a big question, as does the kind of less appealing bathroom issue. In our office, the only time we take off our masks is when we're eating. We have a break room, which we used to sort of communally share in the middle of the day. We no longer do that, so we each sort of retreat to different corners of the office to have our lunch. I would say when I've had lunch in the past few months, someone might walk by to use the microwave and then leave. That person's wearing a mask. I might not be because I'm eating. It is very brief. Someone's literally walking by and walking back out the door. But I have not been within, at least 6 feet, if not more, of anyone who's eating at the same time. And So there are times during the day, if there's a little bit of downtime, if I'm answering phone calls or charting, where I am in the office. And if I'm not seeing patients actively, I'm not in exam rooms, I'm in a wider open space and spaced from our staff, where I would wear, let's say, a plain surgical mask or even a cloth mask, just because the N95s get pretty constricting after 4 to 5 hours at a time. So, that's where we are. That's what we've been doing.
Can we talk a bit about so the teachers who are not really for reopening at this time because of the positivity rates, and they may have family at home with underlying conditions, they may have underlying conditions themselves, whole host of reasons why they don't feel that way. One of the pushbacks that teachers get publicly is that, why do you think you're special? Doctors and nurses are dealing with people who are infected all day long. They're not catching it. Grocery store workers have to be around people all day long. Why do you think you are special? So do you have any thoughts about that yourself? I certainly have beliefs, but I certainly have thoughts about how doctors are different as a profession, but I don't want to sound self-serving. So I'm asking you if you have any thoughts about that.
Sure. Well, so healthcare workers certainly are getting infected and have been getting infected from day one. I'm sure many people saw and remember the heartbreaking video from China of basically the whistleblower for the world. I don't remember his name, unfortunately, but an ophthalmologist who was noticing what was going on and the infectivity and the morbidity and mortality, and literally on his deathbed was taking videos and throwing it out there for the world, and he passed. So he was sort of the index case among healthcare workers, at least the face of an initial wave of healthcare workers who did pass. I know healthcare workers who have succumbed to COVID-19. I know quite a few who have had it and who are still recovering, shortness of breath, exercise intolerance or physical activity intolerance, etc. So number one, I guess, to sort of debunk the myth that healthcare workers don't get it or aren't getting it, that's just blatantly false. Keep in mind also, of the several hundred known fatalities among healthcare workers, by this point in the US, at least several hundred, probably more. There are, for each fatality, probably anywhere from 3 to 10 who have significant long-term morbidity, whether it is cardiac or clotting or pulmonary sequela from the illness. So there's that. I'm trying to remember the rest of your question, sorry.
I guess, do you, I mean, as a pediatrician and parent, you are a parent, I believe.
Yes, yes.
Do you think it's reasonable to, for teachers to feel like the conditions of their work should exempt them from, if possible, going face to face in the classroom?
Right. So, of course, as part of medical training, we are trained in infectious control, infection control. We also take microbiology and obviously various layers of biology and histology and pathology. And so there is a ton of learning that goes into becoming a physician that is about awareness of infectious disease, whether it is the mechanism, the infectivity, the treatment, and the prevention. Number one, the prevention. So I don't think there's a corollary at all between healthcare workers and teachers, is the bottom line. If you throw in grocery workers, the same thing. So, we all take a certain risk every day, even just driving to work. We all accept a certain risk. Could the roof collapse at your school or my building? Sure, that kind of risk. However, I do think it's unreasonable to try to lump any teacher with, let's say, an infectious disease specialist working in an ICU in full protective gear and cognizant of every aspect of the latest data on transmission and infectivity.
Yeah, I would say especially because many of our fellow teachers, their districts are not guaranteeing them personal protective equipment of any kind. They're not requiring students to wear masks. They're really being non-committal about any sort of preventative measures. I just know, I as a teacher, I think every teacher can kind of back this up is, I get sick from my students, probably seriously sick every other year, 3 to 4 minor bugs that I kind of shake off every year. And it's a risk that I accept. I just go into it knowing I should try to keep myself well so I can fight it off. But, we know we're in like this viral stew every day,
Yeah, so I would say, just to be clear, as a matter of community spread, a school would be a much bigger incubator or a catalyst for community spread than, say, a grocery store, a Home Depot, anything like that. You could say that basically.
Oh, absolutely. Yeah, that's without a doubt. That sustained indoor contact. That the grocery store, you're moving around, you're in and out, you're not, seated for several hours at a time, in a smallish or crowded environment. So very different context there.
Yeah. I've heard a lot of discussion about dose and duration. So we know that, like if you're in a room the size that you're in right now, I can at least see the walls behind you. I have no idea what's in front of you. But if I take the cubic area of air in the room you're in, and then I look at Mark, and I can see that it's much larger. Like that's the difference between our classroom and Home Depot.
Mm-hmm.
And that's like, I don't know how much easier like I can make that. But the ventilation, like in some areas of Texas, like where I am, like opening the window or increasing the outdoor air is an impossibility. Like that's
right.
I could open the door, but it's 118 outside. Like
right, exactly. And so that brings up, outdoor education, which is ideal or would be ideal, but it's just not feasible in our environment right now and in much of the country from, maybe early November to late March due to the flip side and the cold. So
right.
So if we go to the topic of PPE. So if you were a teacher, Dr. Propst, how would you go to school every morning?
I would approach it very similarly, if not exactly the same as what I'm doing now, which is I have a designated pair of shoes that I wear to drive to work. I wear scrubs every day. I go to work. I walking from my car to my office. I wear a cloth mask. I remove the mask when I get to work. I wash my hands thoroughly. I put on my N95. I put on my goggles. Obviously, I glove up for each different room and patient encounter, washing hands in between, etc. When I get to work, after I've done all that, I change shoes. I have a designated pair of shoes that I only leave at work. At the end of the day, I sort of do it all in reverse. So, take the shoes off, leave them there, get my other shoes. I bring a change of clothes. I scrub down up past my elbows and change into my kind of go home clothes, put my scrubs for that day in a plastic bag or Ziploc, take it home, go right in, change, leave my shoes outside, I should say, my driving shoes stay outside our front door, go in the house, wash hands, bring the scrubs up to above the washer. They sit there for a few days and kind of rinse and repeat.
So a fresh pair of scrubs every day.
Fresh pair of scrubs every day. I will add about PPE. So we are recycling PPE. So obviously goggles are not necessarily disposable. I've been using the same pair for a while. I broke one pair. And gloves are different, are changed for every single patient encounter. The N95s that I wear, I have a set of 4 and I cycle through them. So I have a day of the week N95, and I keep them for about 4 to 6 weeks on end, depending on how much wear they get, and you know, when they start really getting ratty or the elastic is breaking down, etc.
So the cloth N95s?
These are these are the kind of white N95s.
Okay.
That, yeah, the medical grade N95.
Well, as a physician, how concerned are you about the resources that would be taken up as far as the PPE goes? You got a lot of schools in the United States and you're already short on PPE. So how much of a factor would that be in supplying our healthcare and frontline workers with the PPE? Are you concerned about that dynamic?
Yeah, I mean, there's certainly, just like early on, there was competition among various states for getting PPE for their essential workers. And I would hate to think that there would then be competition between healthcare workers and teachers, for example, for a limited resource. I mean, demand is absolutely still far outpacing supply as far as PPE goes. The faucet has opened a little bit. It's certainly a little bit better, but not to the point where I could ideally, you know, change out an N95 every shift or every day or every 5th day, as would be ideal. Surgical masks are a little bit easier to come by now than they had been. Are there enough for every single teacher and every single student also not to be recycling? No way, no way.
And I've seen some people just wear like a face mask. What would I make a shield, a face shield? Sorry. Apologies. I've seen some people just wearing like a face shield without an N95 or a face mask. Is that just useless?
It's better than nothing, but it's not appropriate, if particularly for sustained indoor, you know, inability to properly space that type of contact. Is, you know, a face shield alone enough to go to the grocery store? Maybe. I wouldn't do it. I would still wear a mask underneath.
Okay. Well, I personally look forward to wearing scrubs. I've always thought they look super comfortable. I hope doctors don't take offense at us, you know, putting on your garb. How about just the risk to kids? I mean, you know, I certainly am most concerned about my fellow teachers, especially older teachers. I'll be honest, a lot of teachers are not in great health. It's a stressful career. They don't have a lot of resources, you know, to take the private yoga classes and fitness classes, and you know, so it's, you know, underlying conditions like obesity and stress and poor immune systems are a real problem with teachers, and so I'm most concerned about them. So maybe you can talk a little bit about who are the teachers who should be most worried, who we should really think twice about going back, and then also how at risk are the kids?
So among the teachers, or really the general adult population, anyone really over age 60 to 65 is considered higher risk, just based on the numbers and the morbidity and mortality data. It appears men, for whatever reason, are afflicted more and more seriously than women are. Not by a ton, but there is some statistical validity there. Anyone with underlying conditions, particularly immune deficiencies, pulmonary issues, severe asthma, cardiac issues, obesity certainly is an independent risk factor. Smokers need to be very careful, vapors as well. And then we're finding more and more that people of color, African Americans, Latinx people are being affected disproportionately, both in morbidity and mortality. So I did see some data a couple days ago that seemed to indicate that about a quarter of American teachers have at least one significant risk factor. So that's a huge number, obviously. And interestingly, that a quarter of our country's elementary schools, and I believe high schools were also included in this, do not have a school nurse on campus. Yeah, so wow. Who's going to be dealing with making those decisions in terms of flu or RSV or the common cold, or is this COVID? And there are a lot of issues there. But so going back to, you know, the teachers who should be most concerned, you know, those are the risk factors. Certainly teachers who are in a setting where they are close quarters, there's poor spacing, there's poor ventilation. If they have, statistically, if they are seeing children age 9 and older, they are therefore higher risk, just based on several of the studies, including that large one out of South Korea. So, you know, that certainly brings.
Well, I'd kind of like to segue into the flu, because I've heard medical experts say that you can carry both COVID-19 and the flu at the same time. So I know one of the biggest problems with COVID-19 is the cytokine response. I hope I'm pronouncing that right, but that's the immune response.
Right.
Do we even have any clue what the human body is going to, how it's going to react to having both COVID-19 and the flu?
No, we don't. So the bottom line is no. And it's absolutely possible that one would have COVID and the flu, or COVID and RSV, or COVID and strep. Thinking of some of the more common diagnoses that we see, particularly among school-age kids. So we don't. And so for children, nationally at this point, there have been about 300 to 400 known cases of the inflammatory condition called MISC, MIS-C, that has been affecting certain children, often about 4 to 6 weeks after COVID-19 infection. It does not appear related to the severity of the initial infection. So someone might be mildly symptomatic or even asymptomatic, and then 4 to 6 weeks later, develop this inflammatory response, which can lead to significant immune, cardiac issues. And there certainly have been some fatalities related to that, but about 300 to 400 that we know of. I, for one, am aware of some that are subclinical that don't fit the full criteria to meet that diagnosis specifically, but who meet several of the criteria. So those might be the ones that are below the radar right now and are out there as well among children.
What about a big question that comes up a lot, because so many people are asthmatic, especially here in Houston, where the air quality is no bueno. Is asthma an underlying condition? I've heard conflicting things about that for children and for adults.
Yeah, absolutely. Yeah, okay. COPD, emphysema, asthma, absolutely.
Okay, thank you. Those of you who are watching, if you have questions, please put them in the comments on the Facebook Live page. Nelsine is tracking those. We'll save those for a Q&A session at the end, if that's okay, Nelsine?
Yeah, absolutely.
You want to go ahead and give us one?
Oh, you're ready?
Sure, why not?
A gentleman is saying he has a son with asthma. It's funny that you just brought up asthma, and a baby due at the end of August, and he's concerned about bringing COVID home. And he would like to know, in his situation, would you seek a work from home exemption?
Would I see a work from home exemption? Well, there are a lot of issues there, obviously. So asthma is considered a risk factor for anyone, for adults, for children. Being a newborn unto itself is an immunocompromised condition. So that child would be high risk. being pregnant. So for the anticipated newborn's mother, that is an independent risk factor. So there certainly are a lot of high-risk individuals in that particular household. So I would certainly advise that family to take it very seriously, to speak with their physician regarding those risks and what can be done to mitigate those risks.
Okay, thank you. So I had a question. You brought up school nurses, that a quarter of schools don't have school nurses. That amazes me because I don't think I've ever worked at a high school that didn't have a school nurse, but I've only worked at large high schools. Do you have any sense if school nurses are getting adequate training and preparation for reopening and how to determine or check for COVID-19?
That's an excellent question. I actually don't know. I don't know if they're getting extra or specific preparation or PPE or counseling or education right now. I am friendly with our local elementary school nurse. I certainly can ask her. She's in the Houston Independent School District. And find out, what type of preparation they're getting. I know the vast majority of them, and certainly the ones that I know, are doing their own homework for sure, and trying to read up. And I have to think their various associations are helping them along with that as well. But I don't know if they are getting any structured, organized, school district supported education or preparation.
Do you feel like school boards are doing the best they can to seek out medical expertise and from their local doctors and hospitals?
I really can't speak to that. I haven't had experience dealing with the school board here in Houston. There's been a ton of turmoil, to say the least, within the school board. I can't imagine that we are alone nationally as far as that goes. So I just don't have a good answer for that. I don't know.
I was just hoping you had heard, there's such a variation. I certainly think HISD is listening to experts. That's why we're not going back at all until October 19th. I mean, we'll be virtual till October 19th. I suspect it'll end up being the rest of the year. But some school boards adjacent to Houston, all over the state, are just going back. No mitigation efforts really at all. So
right.
So
and I think a lot of that is the politicization of it. So I can't speak to specific school boards, but just right. the overall gestalt around the nation seems to be that school boards are about as political as Congress and many other facets of American life right now.
So if you could speak to a school board, like let's say a school board member's listening to this, what would you advise them? What would you say to that board member who has not done the work yet that they need to do, or listened to the right people, or may not have listened to the right people? Where would you tell them to go get information?
I would tell them, at the very basic level, to start by very carefully reviewing both the CDC, the WHO, and the American Academy of Pediatrics recommendations for school reopening. Now, that said, again, those have become somewhat politicized as well, particularly, I would say, the CDC's latest recommendations. There are plenty of sound bites in there that people have chosen to cut and paste in isolation and in a vacuum. But the recommendations very clearly lead with, our primary goal is for schools to reopen safely, and safety being stressed up front and center. Same with the American Academy of Pediatrics recommendations, which were mischaracterized and distorted by quite a few politicians and activists. So I would first advise them to look at those guidelines and to take seriously the recommendations in those guidelines regarding safety. one of the main recommendations that is consistent with those guidelines is for local teachers, teachers associations, school boards, et cetera, to consult with local public health experts and health authorities. So that would be the next step, would then be consulting with the public health experts in your area. And getting the expert advice of the people who are trained in epidemiology, biostatistics, infectious disease, pediatrics, all of it. And then with that information, assessing the context. Okay, what is our local context? What are our various schools like? Can we open windows? Can we have outdoor class? You know, how large a community is it? How many kids are packed into each room? You know, resources for masks, for cleaning, for hand sanitizer, for, you know, again, I hate to dwell on the kind of mundane and gross, but things like toilet bowl lids. You know, there are so many layers that need to be addressed and need to be assessed. So I would hope that school board members would be taking that approach. Of course, they also need to think about the community, the parents, the economics. You know, I'm not saying this is just needs to be done in a vacuum where only the health perspective is taken into account. But the bottom line is, this is a pandemic. It's not a forest fire or a brush fire. This is a health issue. So it needs to lead with medical, public health, and safety guidelines and precautions.
Well, now, my sister, she lives in a nursing home. And on the subject of politics, I kind of know that the medical sector has kind of been taken over by lobbyists, insurance companies, and just recently, like you were talking about, who has the qualifications? Well, there was a petition by 1,500 doctors funded by the Mercer family and Home Depot that essentially is basically buying the science. And we had Trump essentially take over the CDC and change things. So I know in my experience that if a doctor goes and prescribes my sister therapy, it's under managed care in Texas, which means they defer everything to the insurance company. So the insurance company often overrides the doctor. So my question about politics within the medical community, is there a movement to kind of get this sort of influence by billionaires out of medicine?
I'm glad you asked that question. And absolutely, if there's any good that might come out of this just horrific pandemic, it has motivated and mobilized the silent majority, I would say, in medicine. I know, for example, here in Texas, the Texas Medical Association traditionally is considered a nonpartisan organization. They normally donate to both parties' state conventions and are basically on the sidelines. They try to kind of stay out of politics. Which is admirable, and I think up until perhaps a few recent elections, it made sense to a large degree. I think, however, with the pandemic, we have seen misinformation, disinformation, and cherry picking of certain quote data or pseudoscience really become weaponized politically. And it has undermined the public trust in the public health system, in our health authorities, and in physicians. So, for example, the Texas Medical Association, back to that, quite a few of us basically pushed back and got the TMA to get off of the sidelines and to take a stand. And it was regarding one specific issue here in Texas, a large indoor convention that was being planned for just a few weeks ago, about 6,000 people, many of them pretty adamantly anti-mask, who were going to congregate here in Houston when the positivity rate was over 20%. And you know, just down the street from the Texas Medical Center, which is already overflowing, and essentially overwhelmed. So quite a few of us got together and really got the TMA to listen and to act. And I think that nationally that's happening as well. Now, unfortunately, this week in particular, I think the media seized onto a certain group of physicians. They weren't all physicians, actually, who had a photo op and a video that went somewhat viral. There's one physician here in the Houston area in particular who got a lot of notoriety over that. There has been tremendous pushback by the legitimate medical and public health community over that. And so that video in particular, for example, was removed from certain social media sites, and several medical organizations came out with statements specifically with regard to some of the misinformation that was shared in that video. So the short answer to that long comment is that, yes, I think that the medical community is becoming more vocal, more active. We are now really trying to deal with things like the social determinants of health, whether it is poverty or gender or discrimination, access. There's so many layers, so many factors, and you really cannot separate all of those from medicine in America right now. So.
No, I'm glad you said that, and I just wanted to express, I mean, this whole last week has been so crazy, and I felt a great deal of sympathy, because the doctors I know are all extremely serious people who have spent their entire lives, dedicated to science and helping people medically. And for the entire national conversation to be about like demon sperm and alien DNA, it's like doctors have important things to say, and there's just there's no room to say it because of these sideshows. Right. So I'm glad you're here having this conversation with us. I have a quick question about, so one of the sort of major axis in this debate about it's all about the kids and should we send the kids back to school, is mental health of children versus physical health of teachers and children. And a lot of pro-opening parents are really making a very, I don't know how to put it, they're really stressing the mental health of their children, that they feel like this is as dangerous or more dangerous to them from a mental health side of things. And I know as a pediatrician, you deal with, you're the first line responder to encountering mental health issues with kids. So I guess, do you have any thoughts about that?
Well, there's no doubt that this pandemic will have massive ripple effects with regard to mental health among adults and children. Also, we are becoming more and more concerned about developmental milestones and the effects thereupon of children not being socialized and around other kids, etc. It won't be easy, and we will certainly need plenty of resources to help address those issues. There are many sides to that as well. So there are some children who thrive off of being around their peers, who feed off of that, who learn, who I have no doubt learn better in an in-person, face-to-face situation. I can tell you from my own household, I have one who seems to enjoy virtual learning and feels it streamlines his day and his education, and another who really can't wait to get back into the classroom. We are absolutely seeing more children with anxiety. And so a large degree of that, I think, comes from just what they're absorbing. They're exposed to the media as much as we are. If you have the evening news or the radio on in the car, for example, or the TV on at home, your child of any age is absorbing that. Even if they act like they are not watching, not listening, they are playing with their Legos or whatever. So they are absorbing what is going on around them. And so we certainly are seeing anxiety. We're seeing some more depression. I've seen a little uptick there. I can't say it's been a tremendous increase. We, interestingly, and sometimes this happens naturally over the summer, are seeing fewer visits for attention deficit hyperactivity disorder, among other conditions. And that, again, can be seasonal. Some parents choose to take their children off of medications over the summer, take a vacation, for example. But that's been an interesting thing that I, for one, have noticed. The flip side of that is having a child in a classroom where he or she is afraid of the environment, of the teacher, of eating their lunch, or is then exposed to the illness or death of a classmate or staff member or teacher. So there's a lot to balance there, and it is very difficult, absolutely. And as I said, best case scenario, even if this were to end right now, we as a country will be faced with a tremendous mental health issue, kind of a second wave pandemic from that alone.
Well, this would be kind of a teacher comment, but I've noticed there were certain kids in my classroom when we switched over to online that were very reserved, and they came kind of alive during online. They were better. So in teaching, they kind of tell us to differentiate. They want us to differentiate the learning. So certain people have different learning styles, and we need to cater to those different things. I think going forward, one thing we should have learned from this is that sometimes students do better in person, and I think others did much better on online. So I think that's something to consider going forward.
Right.
And sort of a hard transition, I had this question for you. You probably know more about it than me, is the medical bills. So a lot of people are, they're taking a risk with their life to keep their livelihood. And I just wanted to see if you had any inside info on how much the average COVID case, if it got severe, how much would that cost you even with insurance? Do you have any idea about that?
Boy, I don't. And I have to think that would just vary so much depending on insurance, out of pocket, regionally. Severity would be the huge issue, obviously. I know in this area, many insurance companies are covering COVID testing. And then depending on the outcome and depending on the severity of illness, medication, et cetera, and copay and all the different tiers and layers of billing and insurance come into play. So I don't have an exact answer for that, but it's a cost. It's a cost. And certainly even just getting the test itself is a cost. So.
Well, say the average ICU visit in Texas, what would that cost you? Do you have any? Because fortunately, I've never had to go to the ICU, but I'd imagine it'd be quite expensive.
Right.
Even if you had insurance,
Yeah. If you're talking about an ICU stay, and let's say average, if you say ideally a 2 to 5 day stay, for example, with COVID, obviously many are far longer than that. But I would say if you're looking at an ICU, you're looking at tens of thousands of dollars.
So,
and that's with insurance.
No, that would be sort of my rough estimate for without insurance. If you were having to pay with insurance, I can't speak to that. It would just depend.
We all have caps. We all have caps and deductibles, but it would be bad. So vaccines. What are people? I've heard so many different things. Like next year, second quarter, hopefully, maybe this fall something will happen. What are you hearing?
Yeah, I mean, the race is on right now to get the vaccine out. Of course, the limiting factor there is number one, production and the technology and the science, but the biggest limiting factor is just the time, right? You can't do a vaccine and say it's efficacious 24 hours later. You have to wait that time and have some exposure to know if it was protective. So that time lag alone takes us, months from now. There are different vaccines in production, at least 7 or 8 right now that are underway. I think Dr. Fauci, as recently as yesterday, it might have even been earlier today, said that he was hopeful there might be one available before the end of the year. We don't know what form that would take. We don't know what duration of immunity that might provide. We don't know what age group that's for. There certainly are vaccines that are given specifically to certain age groups and at certain age ranges, both for their efficacy and the prevalence of certain illnesses among certain age groups, and for safety reasons. So there's still a lot of questions there.
Do you think that, is there any way of knowing if how the efficacy will compare to, say, the flu vaccine? Because, as teachers, we get flu vaccines, we're offered flu vaccines every year, and it's just a crapshoot if it works or not. Honestly, I'm sure it provides some prevention if they predict the right strain that year. Is there some sort of similarity there with the vaccines that will come out for COVID, or is that a whole different ball of wax?
It's a bit different. It is a bit different. And some of that is the known seasonality of flu. Some of that is the predictive effect that we can have from, let's say, Australia or other parts of the world where flu might be hitting at a different season, and that affects the vaccine composition for the following or subsequent flu season. So they're not exactly comparable. I will say, though, that by and large, the flu vaccine has saved tens of thousands, if not hundreds or more, hundreds of thousands or more lives globally. And if there was ever a year to get the flu vaccine, this is it. So I've gotten it every single year, I believe, since I was about 14. And I
do too. I was not trying to put down the flu vaccine.
I just wanted to make that clear.
No. I am pro flu vaccine. I am pro vaccines across the board. Back to the flu. So the flu is this sort of seasonal southern hemisphere in the summer, and then it comes up to us in the northern hemisphere, and then it goes back down. But is there any idea if COVID's going to do the same thing, or?
We really don't know yet. There has been some discussion and some question about whether there have been various mutations. Originally, there was a thought that there might have been an Asia strain and a European strain, and that the Asia strain hit the West Coast and the European strain may have hit the East Coast harder. The studies on that are pretty equivocal. I haven't seen anything that clearly supports all of that. Recently, there was some question about whether Houston in particular was being hit by a more virulent strain. Again, I haven't seen anything conclusive or definitive about that. We just don't know. It's a novel coronavirus, so we don't know.
Okay. Well, yeah, it's a cousin of the common cold. I know we don't really have a vaccine for the common cold. So I guess one of my questions to you would be, and I've never seen a vaccine or a push for vaccine this fast or to come out this quick. How wise would it be, let's say we do get a vaccine and we kind of rushed it, how wise would it be to just start reopening everything based on a new vaccine for a new virus?
Right. I mean, so again, with any vaccine, the proof of efficacy is time and exposure. So, I certainly, just like with our 2-month-olds who we see in the office who are getting their first big round of vaccines, including their pertussis or whooping cough vaccines, I always tell parents, there's nothing magical about the moment you get your vaccine that means you're immune. It takes time for your body to mount an immune response to any vaccine, number one. And then number two, with a new vaccine and a new virus, do we know that 5-6 months out or 1 year out, you would still be protected? We don't know. There seems to be some emerging data that within the first 3 months after having COVID-19, many people appear to have antibodies and have some immune protective response, meaning if you have COVID-19 and recover and are then exposed, let's say 6 to 8 weeks later, there is emerging data, and the CDC, latest CDC guidelines reflect that there seems to be a protective effect and antibody production. Beyond 3 months, though, it's a crapshoot.
I have one last question, and if anybody out there has questions for Dr. Propst, please put them in the comments, and then we'll take it over to Nelsine and any questions she or Michael might have. So just sort of speaking, and I think for this question, you might have to take off your doctor hat or scrubs and put on your American citizen, sort of global American citizen and policy hat. So I think Dr. Fauci recently talked about how in Europe, they did a really good job for the most part of truly shutting down the countries. Like 95% of what they needed to do, they just masking, social distancing, shutting down schools, shutting down businesses, except for the absolutely most essential businesses. And they have infection rates that are, I mean, I don't want to say they're negligible, but they're not that dangerous. I mean, it's anybody who gets sick with COVID it's horrible. But and he said, I think Fauci said, like in the United States, even in the best states, it was more like 50% of what you needed to do. And here we are, over 150,000 dead Americans later. In my opinion, I hope we do what we should have done in the summer, which is that 100% state or ideally nationwide lockdown, really get this pandemic under control. And I think Dr. Peter Hotez here in Houston has like an October 1st plan, that we can really do this. We can really get this pandemic under control, but I don't believe it can just be sort of a, well, let's see how it goes first in the schools, and let's maybe kind of shut some places down, maybe not, you know. What do you hope we will find the national or at least statewide will to do to really get this under control?
Yeah, and
I know you may have to be speaking again as just a private citizen here, not as a doctor.
Sure.
If I just add a little bit to that, I would just say the one thing that the United States did right was shut the schools down preemptively. And so it just seems kind of insane that you would open them back up when we already have these high levels of infectivity in all these places. One of the best things we just close the schools down because they could be a super spreader. So I would just add that to Mark's comment.
Yeah, I mean, if you look at what happened in Europe and in Asia, they did really shut down, and not piecemeal, not state by state, not, you know, a couple dominoes falling every few days or every few months. They really just took it seriously and shut everything down. Sporting events, non-essential businesses, restaurants, schools, all of it. You know, here in Texas and here in Houston right now, restaurants are still open for in-person dining. That is perplexing. It is not helpful. Ideally, we would have already weeks ago, when we first started seeing this real uptick, had a shutdown, a stay at home, non-essential businesses closed. You know, yes, that's extremely painful for a tremendous number of people. And economically, that is extremely difficult and painful for many, many people. That said, we have prolonged the agony by not doing so. The uptick here in Texas, for example, really started right after phase 3 of reopening. So things were looking better. We had that initial surge, we shut stuff down, things looked a bit better, and then we gradually reopened without meeting the criteria of the 14 days of decreasing incidence and the other parameters. And so that rush to reopen is what just opened the floodgates. And those floodgates are still open. Youth sports are still happening. Traveling baseball teams, preseason sports are still happening. Restaurants are still open for in-person dining. It is, from a public health perspective, really contrary to both science and logic, what is going on right now, and it is just not helpful. It is making this a longer, more drawn out, more difficult process.
Yeah, and I want to follow that up with a statement that I made in our previous video, our first video. I'd like to make it again because I want to make it every time we have one of these Facebook Live interviews for teachers and for anybody else who is watching, that all teachers want to go back to work. We want to go back to work in our classrooms. We want to be with our students. The idea that we just want to sit home and collect paychecks and not do work, or that virtual learning is easy and we're just eating bonbons and in our slippers, is that's not true. Virtual instruction is actually really difficult and stressful and complicated. We would much rather be in the classroom. We all want to be back in the classroom. So on that note, I want our leaders to do what they have to do, even if it's painful in the short term, so that we can all get back in the classroom full-time, face-to-face, safely, and resume normal life. And it pains me that people were distracted with these arguments about what teachers do, what people think teachers want to do. And I know it's the same for doctors. You are also not doing normal business.
Right.
I just made an appointment with my family physician just because I needed a physical checkup. I skipped the last few years, which I know is not good. So I was like, okay, I really need a checkup. And my doctor has gone down to half telehealth, half in person. That can't be good for him and his income. Right. I can't get the earliest physical checkup I can get is September 22nd, which is crazy. I can get a visa to go to Germany and get a checkup faster than I can get a physical exam here in my own country. So I know for you guys, things are not right and normal. And as long as we continue like this with up and down waves of infection, you're not going to be able to go back to business as usual and your own practices. So,
Right.
And I know you would love to. You would like to see patients all day.
Right.
Right.
Right. Yeah. Yeah, absolutely. And so the pandemic has had a really catastrophic effect, particularly on small practices, on rural practices, on rural hospitals, as well as hospitals here in bigger centers. Here in Houston, for example, the medical industry is a huge driver of the economy. I believe the last numbers I saw, don't quote me on this exactly, I think it was about a third of the local economy was in some way related to healthcare here in Houston. And that community as a whole has been hit very hard. And I'm not just talking about the stress and the work and the anxiety and lack of sleep, et cetera, just the bottom line. So it's certainly, we are not immune by any means to the economic consequences of this.
Nelsine, do you have any questions that you wanted to ask from your perspective over there in Arizona, where it's even hotter than Houston, I probably bet?
Yeah, it's 118. So So yeah, when I hear people talk about, you could just open up the windows and, increase that ventilation. And I'm thinking, well, I could cook my students, or like, no, that's not really ideal. But how, in the category of things that, like surface cleaning and hand washing and the things that we hear about all the time, how much more or less significant is that ventilation? I mean, when I look at my classroom, the thing that schools have been so focused on recently is the school shooter, right? We do all these drills, these active, shelter in place drills and all of this. So everything is locked down. Like our school, they just did like every single door with a peephole. Our doors have to remain shut and locked through the entire school day. Like those things have just been put in place. How do we transition to, just open the window or, increase the ventilation? And I'm thinking, wow, what a change.
Right. Yeah, it's there needs to be some middle ground there. And certainly safety doesn't just mean safety against coronavirus. Unfortunately, in this country, we have other major safety issues, particularly for teachers and for students in school. But going back to just the air or the ventilation, the data is quite clear that poorly ventilated spaces that are small, closed, indoor, large numbers of people, poorly spaced, particularly if they are unmasked, but even if they are masked, those are higher risk environments.
Excellent. Yeah, and Mark, thank you for bringing up again that really, there is no place I'd rather be. I mean, having to put together a virtual classroom and try to integrate all these other things with technology it's not a walk in the park. And
no,
who's doing it right now is not just sitting around in their bunny slippers collecting a paycheck. Living the like,
it's
right.
It's all of the work and more, but without the joy.
Yes.
Yes.
Yeah. That's gratification that we actually get being face to face.
Yeah, the actual the laughter and the spontaneity. And so if teachers are saying, please let us stay home and teach virtually, I promise you it is not because it is less work or
right. And you said that last time. I want to say something again that I said last time. I quoted Voltaire. He said, "Don't let the perfect be the enemy of the good." And so this is certainly not an optimal situation. We definitely want to go back. However, we care about our kids. We care about the communities we live in. And that's why we're so adamant about this. So, and I just have one more question and I'll be out of your hair for good. There was a case of a summer camp in Missouri where they did all of these social distancing masks and they caught it. It was like 80 plus people got infected with COVID-19. I know when they opened up the schools in Israel, there was a problem where they had to shut them right back down. Just wondering, how did they get such a high level of infection when they were doing all of these quote unquote safe procedures? What was the main mode of transmission, do you think, in those situations?
Right. So the index cases, just as we sort of mentioned earlier, all it takes is one. All it takes is one person who thinks, oh, I can just go hang out with my friends and not social distance and go to my friend's house and I'll be fine. I feel fine. And now I'm going to go to camp. All it takes is one. And, as I've been telling people about the camp model, and that camp in Missouri got a lot of press. There's a camp here or in Arkansas that draws a lot of people from Texas that got a lot of press as well. And I think that certainly they tried to institute the best measures they could. Many parents, I think, considered it to be a bubble. And I know even before COVID, people would talk about summer camp as the bubble, the happy, shiny place for the summer and all of that. There is no bubble. Those camps still need supplies. they still have people coming on and off of campus, bringing food, bringing, sanitation, bringing workers to fix what have you. They still have staff who might not live in the bubble and go home. And so all you need is 1 weak link. And there you go. And so I think, while I don't know exactly what the index case or what that person was in Missouri or in Israel, I believe actually in Israel, I might be thinking of a different study. There was one in Chile, actually, now that I think of it, of an adult staff member at a school who, it was one index case was traced. They had good tracing, and that one person ended up, I actually wrote it down, I think 52 cases were linked to that person. This was at one private school. Of the ones infected by that one adult staff member, 13% were students, 35% were staff, and then 52% were actually parents, interestingly. So it was adult staff who interacted a lot with adult parents and other adult staff. And that was the big mode of transition at that one particular study and one particular case out of Chile. So all it takes is one.
Yeah. I want to maybe one last topic. We really appreciate the time you've given us. I think it's an important topic. And we talked about it. It came up briefly when you mentioned that our Black and Brown Latinx populations have a higher rate of morbidity and infection. Why is that? Because of underlying conditions due to poverty, or are there other reasons? And that's a major concern I have. I teach at a Title I school. 89%, I don't know what it is, children of color. So I don't know why is that a major issue? And Nelson, I learned, has a large Native American population, and I've heard it's just ravaging tribes and reservations. So do you have any thoughts on that?
Yeah. So, I mean, it is clear that there are social determinants to health that are skewing the preponderance of those affected to Hispanic, Latinx, persons of color, African American, et cetera, in this country. And whether that is related to something associated with the virus per se. There was some discussion about blood type initially that has since been really questioned, and really there's not a clear link there. But the biggest issue, I would say, number one, is access to healthcare. So often in communities where there is poor access or poor trust of healthcare providers, those folks wait too long. They wait until it is too late and they've already infected quite a few other people, for example. That's number one. Number two, the comorbidities, of course, are a huge issue. So there is a very high rate of obesity, of hypertension, of diabetes that skews more in certain racial and ethnic populations in this country. There is a higher preponderance of multi-generational households in certain communities. I know in Houston, for example, I believe the Latinx community has that distinction of having more households with multiple generations. And so that means more people of stratified risk based on age alone, and possibly, the teenager who thinks he or she is invincible with the 90-year-old great grandma, all living in the same household and in relatively closed quarters. So those are just some of the factors, but yeah, and I'm sure Nelson can comment as well. In the Native American population, I know obesity and poverty and alcoholism and, their poor access is a huge issue. So I'm sure there are more that I'm not mentioning, but.
Yeah, poor access and trust are big ones. Like those really tie in.
Nelson, is there a nurse at your school that you teach at?
We do have a nurse. Yeah, there's about 3,500 students at my school.
Okay.
So, but we have a nurse.
For how many kids?
3,500.
Wow. That is not enough, I would think.
No. And when I think of transmission, her office, I mean, she has a cabinet that has, things that are frequently accessed by the kids that they can just come in and get, feminine hygiene products, Band-Aids, things that they can just come. So they're touching all this stuff in her office. So that's just, I mean, I'm just thinking of all the processes involved with our nurse individually that are just going to be those points of access that.
Right.
Yeah, my school has 2,400 kids. We have one nurse. She's great, but when she's sick or when she's absent, there's nobody. Like the kids just go to the bowl. They just get in the office, and like, I have a lot of questions. What's going to happen? When the nurse gets sick, if the nurse gets COVID, like who is the front line of defense when you have one healthcare worker on a campus of 2,400 kids?
Right. Yeah. And the point of access is an important point, actually, that Nelsie made, because, for example, on any given day in any elementary and high school setting, there are kids who have either asthma or ADD, ADHD, or diabetes who have to go to the nurse to access their medication. And so you're bringing students into an environment where, of course, someone who might be under suspicion or a person under investigation for COVID-19 or flu or RSV or what have you would be. So the spacing and the timing and all of that comes into play as well.
Yeah.
Absolutely.
And I think and I wanted to mention again for viewers who maybe aren't familiar really on a granular level of what it's like to be a teacher around with, from 20 to 40 kids in a classroom for 8 hours a day. We are exposed to everything. And you mentioned earlier, fortunately, I like to think in my mind, I haven't been exposed yet to fecal matter, but I'm sure I have, unfortunately. Saliva, vomit. I'm a high school teacher. Lord knows what the elementary school teachers have to deal with. I mean, and I hate to get this graphic, but I feel like I need to, because people don't truly understand. Like, I've even once had to clean up menstrual blood from a chair. As a male teacher and at a high school, things just happen. These are kids who are not in control of their bodies, and they are not their brains are not developed. So the idea of them having the self-discipline to stay masked all day, I have a lot of questions. So, I mean, as a pediatrician, like the kids don't wear masks, right, when they come to see you, or do they?
We do recommend that kids, if they are able to, that they wear masks. So the majority of the older kids that I'm seeing now are wearing masks in the office. We don't recommend it for children under age 2. I can tell you with my own kids and with my patients that it is the rare 2 to 3 to 4-year-old who will tolerate a mask. But the older kids, many of them are coming in masked. We have masks for patients who come in without masks. And as part of the checkup, or depending on their symptoms and what we're assessing them for, we'll briefly have them take the mask down, take a look at their oropharynx and their nose, put it back on, do the rest of the exam. But it's not, they're not wearing it for an 8-hour stretch as they would at school, for example. It's, usually a 15 to 20 minute time in the office. So
do you have any tips for dealing with parents, or maybe in our case, fellow teachers, or teenagers who refuse to wear a mask for whatever reason is in their head why they shouldn't have to? Like, how do you approach that?
Yeah, that's complicated. And of course, as a teacher, it's very complicated because you don't exactly have the, I hate to use the word authority, but to just kick a kid out of your classroom for, I mean, I don't know. You tell me, you probably obviously know that better than I do, but
we don't know. We don't know if we're given that authority.
Right. Yeah. So I'm in a group, I'm in a private practice where we can essentially, set some parameters on what we expect. And so we expect all the adults who enter our practice to be masked. And so adults who show up without one, we provide them one. And fortunately, I have a lovely patient population, generally educated, informed, trusting, and loving, who are as interested in protecting me as I am in protecting them. So I have not had to have that discussion actually up until now. I think I'm probably in the vast minority of physicians who has not had to deal with that.
Yes, in fact, in the comments, one of my co-teachers at my high school gushed about your practice, and his son goes there and he loves it.
Oh, that's
so
sweet.
You have fans for sure.
Well, thank you.
In the Houston community. I'm glad my kids are basically aging out of pediatrics. All right. Do we have any other questions, Nilsine, that we didn't get answered? Or okay.
We got them all in.
Okay. Well, I don't want to take any more of your time, Dr. Propst. I really appreciate your generously giving us your time and answering so many questions. I know a lot of people are going to see this video, and it'll give them a lot to think about. I'm hopeful that it will result in them looking for information, medical information that's science-based, data-based, and they will use that to treat, make good education, help urge their policymakers to make good education policy, and really statewide policy, so we can beat this pandemic. Not just like kind of suppress it so we can get through it to football season, but really so we can have a real football season. Like, I'm a huge Rockets fan. I don't want to see them play without fans. I want to go to a Rockets game. So I really want to beat this pandemic, and I think we need to be listening to more doctors, more virologists and epidemiologists, hard word to say, epidemiologists, and making policy based on what they say and not what we wish they were saying.
Exactly. And I think we kind of have put the cart before the horse. We're not going to get back to business as usual until we get control of this virus. And that's why we need to listen to the experts like you. So I do very much appreciate you coming on.
Thank you.
Giving us
My
all this
pleasure.
information. Thank you, Doctor.
So we have a lot of people from around the country in our Facebook group. And I want you all to know this is a real Houston doctor. So when you hear about Houston doctors, remember Dr. Propst, and not other people who might be in the news right now. So, thank you, Dr. Propst.
Thank you for inviting me. I enjoyed it anytime.
Okay. Bye-bye. Thank you, Nelson.
Bye.
Bye, Michael.
Bye. Thank you.
Thank you.